Good afternoon, ladies and gentlemen. I'll be happy to take you around this very important clinical topic, diabetes. The journey of this topic will be to say what are the peculiar or uncommon or unique infections in diabetes and how the immune system is altered in diabetes to promote this infection, what these infections do to diabetes and what diabetes does to them after recognizing how to take it forward. The next 20 minutes I'll try to do that. See, diabetic, as all of us know, is a pan-metabolic disease. The number is going on rising. Sure, our nation will be the world capital. The infections in the global data says it's around 21%, whereas in Indian data says 19.4, probably almost same. As all of us know, the 5 common infections are in urinary tract, skin, soft tissue, tuberculosis, pneumonia, and foot. I would like to stress infection may be often the presenting feature in diabetes. And continuation of these incidents, both non-diabetics and diabetics, they are visiting an OPD or an IPD for an infection goes from the range of 46 to 38. And contributing to the mortality of the clinical problem, infections alone does it nearly about 46.5%. This is the data. And why this much common infections? There is, all of us know, there is an alteration of immunity. Immune status we classify into innate and adaptive. Diabetes always affects the innate immunity. Most commonly the polymorphonuclear leukocyte. Their adhesion, their movement, their chemotaxis, phagocytosis and intracellular killing, all being affected, becomes very slow. Therefore, infections flourish in this milieu. And the pro-inflammatory cytokines like TNF-alpha and interferon, interleukin-1, 8, they are increased and they also cause an increased flux of the glucose. And the complement system is an important arm in fixing up the organisms which is becoming weak, especially C3, which is commonly contributing to the the contraction of fungal infections. In chronic infections also it continues. In addition, the immunoglobulin arm is also deficit. Thereby it promotes infection. Type 1 diabetes, the helper, that is CD4 cells are very much deficient, which is reversible when you restore the glycemic control, which very well proves that this hyperglycemia is definitely contributing to suppress the immune response that favors the infections. Of course, the alterations in the endothelial functions and angiopathy and sensory motor are contributing. This is the diagrammatic representation of the infection, the phagocytosis cascade coming out from the blood and then trying to move and then phagocytose and then engulf and then cellular bursts. This is normally happening. In a diabetic patient, this movement is very much reduced and this complement fixation is defective. That leads on to flourishing infections. The other factors are a vascular factor, can be a microvascular or a macrovascular or an endothelial dysfunction or an angiopathy, which always promotes for a polymicrobial growth. And the neurogenic factors in the foot, we know that because of absence of sensation, even smaller cuts and wounds progress towards an active infection and amount to nearly 60% of the non-traumatic amputations of the foot. There are various tissue factors also. Hyperglycemia as such increases the intracellular glucose, thereby it leads on to these 2 important pathways and whereby the osmotic cell injury and an oxidative cellular injury and an increased carrier state of the staphylococci. Most of the atypical infections are due to staphylococci. That's the reason they are being harbored. These are a few triggering factors which we have discussed earlier. In addition, these diabetic patients, as we know, when they are in uncontrolled hyperglycemia, they go for a ketoacidosis and frequent intravascular access and then antibiotic uses and hospitalizations, and a gastroparesis or an autonomic neuropathy of the urogenital system, and a chronic renal failure requiring dialysis. All of them promote infection occurring in these people. This is the conventional classification of infections in diabetes. We will deal with the second half of it, the peculiar infections. We have been listed here. We will try to briefly go through them one by one. This is, the first, unique or a peculiar infection in diabetes is a rhinocerebral mucormycosis. It's an invasive fungal infection belonging to the Zygomyces group, Rhizopus oryzae. And what happens is the fungi goes through the nasal turbinate being inhaled, and it starts invading through the sphenoid sinus and into the frontal lobe, cavernous sinus and whatnot. And clinically we have this classical facial swelling, but the important clue is the black yesha, which can be seen outside or inside the nasal turbinate or something like that in the palate. When you see that, you must always think that what we are dealing with a case of a rhinocerebral mucormycosis. And though from the secretions you can isolate the hyphae, but the ideal way is to do in a non-invasive radiological method like an MRI, which shows you a classical invasive fungal infections. And the treatment is an excellent debridement surgically, plus combination of an amphotericin B. Preferably a lipid form is always effective, but still the mortality rate seems to be very high. Another very simple infection which can be very peculiar and life-threatening is an otitis externa. This has been named as a malignant or an invasive otitis externa, commonly caused by Pseudomonas, can always combine with aspergillosis. Main problem is a severe pain in the ear, and there can be a purulent discharge as you see here, which can be a normal CSOM, which may be ignored as a CSOM, but when you look at the tympanic membrane, classically the tympanic membrane is intact, and there can be a neurological manifestation, especially a seventh nerve. When there is a severe pain in the ear with a discharge, purulent discharge, an intact tympanic membrane, and cranial nerve involvement, it speaks or labels the condition as a malignant otitis externa. And we can try to, though radiologically a simple X-ray may be normal, but a CT will be able to, MR will be able to tell you from where this is coming up, and this invasive granulation tissue, you will be able to see that. And the surgical, the diagnosis is again by a culture and a clinical appearance. Therapy is again a surgical debridement and an antibiotic, usually a combination of a extended spectrum penicillin and an aminoglycosides are always useful. May need metronidazole, but in a milder infections, one of the quinolones may be able to control. Without a prompt recognition and therapy, because of its invasive nature, the mortality goes up to 40%. This is a very simple infection which we are often missing in our day-to-day clinical practice, because teeth infections or odontal infections, gingival infections are often ignored, especially in our rural population where the dental hygiene is bad and chewing of the tobacco and pan, everything is there. But this always indicates that the diabetes is poorly under control. There is again a bidirectional correlation between diabetes and a periodontitis. That is, diabetes promotes periodontitis, periodontitis promotes diabetes. I will come to this when I close this session. How these peculiar infections promote or precipitate or induce a new onset diabetes. Can be a gingival problem, periodontal problem, and a resorption of the bone, and the teeth may fall out. An adequate management always not only controls this, but also controls the diabetes also. And emphysematous are a gas-forming organs infecting. Cholecystitis, calculus, date in and out we see in our clinical practice. But an calculus cholecystitis is the classical pain in the right upper quadrant with or without a jaundice. You must think that it can be a emphysematous cholecystitis. What's the clue? You take a plain X-ray of the abdomen, which can show the air here, and excellently on a CT, there is a necrosis of the wall and infection by the gas-forming organism like Clostridia and anaerobes. That gives you this picture. There is no second line of therapy here, only an emergency cholecystectomy. It can be there in the urinary system also, right from the upper to the lower urinary tract. Can be in the pyelonephritis, in the pyelonephritis also, plain X-ray, you will be able to see that, and a CT is very well, telling you, can be a classical flank pain of a pyelonephritis, long-standing hyperglycemia, and an autonomic neuropathy of the genitourinary system with incomplete emptying of the bladder or precipitating factors here. And a CT always gives you the diagnosis. There are medical and surgical managements, but experts feel and studies feel it will end up in an emergency nephrectomy. You'll have to keep it in mind. And a cystitis, an emphysematous cystitis, an infection above, can come below also. But this is less vigorous than a pyelitis. Usually responds to a medical management. But the classical clinical picture will be an hematuria, patient passing air, or can be a hematuria. These diagnoses, even a plain X-ray of the pelvis will tell you, and a CT will classically show you the air in the inner organ. Usually it responds to medical management. And a word about the skin and soft tissue peculiar infections. See, skin and soft tissue infections form number 2 of the kind of infections in diabetes. Can be many types here, right from a furuncle boil and cellulitis. Can be a furuncle, cellulitis, and then bulle. But the classical ones that we should take care is a furuncle and a pyomyositis. Furuncle is a collection of, carbuncle is a multiple boils. Though this is rare today with the improved hygiene and the better control of diabetes, but still when it occurs in the nape of the neck or the back, wherein deep tissues are there, main issue here is it appears on the skin, but it starts penetrating down into the deep fascia, and it can go for a systemic manifestations also. Therefore, without continuing, limiting only to antibiotic, an extensive clearance is needed. Same way, a first collection has to be dealt with surgically. This is a necrotizing fasciitis, which is a very dangerous condition. May look like a subcutaneous infection, but it spreads to the fascia and it can endanger the life of the limb as well as a lot of systemic complications. May need therapy in the intensive care unit by the local color and a woody hard feel and dishwash watery pus coming out. You will have to always think that it is a necrotizing fasciitis, which is very dangerous. It needs an ICU management, surgical, medical. In addition, a hemodynamic management is needed to save the life of the patient. This corneous gangrene most of us have seen is there in the perineum, again by a gas-forming organism. Usually spares the testis. Here the classical sign is the thickening of the skin, reddening or black, but the classical blue is by the crepitus. When you feel that there is a crepitus, always speaks, full surgical debridement is needed. A fungal infections right from the oral and to the esophageal, genitals is very common. Often this is a presenting feature, especially in women. Therefore, we will have to be very much careful on that. May need a systemic antifungal, but this always indicates the immune status of the patient is very poor. Whenever I see an esophageal candidiasis, I always recommend an HIV. To that extent, an immune status is at stake here. A word about tuberculosis, all of us know we have got a resurgence of tuberculosis and an extensive non-communicable disease form diabetes. Both of them link well. Can be either a latent infection or can be a reactivation, but there are a few peculiar, few peculiar forms. It can leave the apex, come down, and multilobar, multiple cavities like this. They are all, peculiarities. You will be able to make a diagnosis through the, bronchoscope. If you have the, pulmonary physician with you, a lower lobe involvement, multiple cavities, less of sputum positivity, more of hemoptysis must make you to think this is again tuberculosis, not a community pneumonia. On the latent tuberculosis can also be treated by American Thoracic Society's recommendation by chemoprophylaxis. whether to have a 4-drug regime or a 3-drug regime or a 6-month regime or a 9-month regime or an extension to 12-month regime. It's all there in the controversial stage, but I for the one believe that a 9 months therapy has to be given, 4 months intensive therapy, maintenance of 4 drugs intensive and 2 drugs, maintenance. A fungal ball is not uncommon, can present silently on an X-ray after a cavity, but can have a fever, cough and a hemoptysis, may lead on to a resection. One of the recent fungi of the same group is a Penicillium capsulatum, which is always detectable on a CT, but it responds very well to oral antifungal. Mellidosis is an upcoming infection, systemic in a gram-negative infection. It presents as multiple abscesses like furuculosis, but abdominally in the liver you can have a lot of nodules which have a honeycomb or a Swiss cheese, which makes the diagnosis possible, and it responds to septicity, may need a maintenance therapy of cotrimoxazole with doxycycline. And asymptomatic bacteriuria, I wanted to make a mention here because this is often detected in diabetic women that does not need treatment except in these 3 indications that we have put in, that it can be, otherwise we don't need it. This pregnant woman before a neurological intervention or renal transplant. In virus infections, enterovirus, cytomegalovirus virus are common, but I would like to stress for one of time hepatitis C virus which is coming up. Hepatitis C virus is more often associated with diabetes, rather precipitates diabetes. The pathogenesis of diabetes by hyperinsulinemia and secretions and increased iron stores are there. And again, human immune deficiency virus, the combination of both are deadly, and the HIV itself by the viral load or low CD4 count or a heart therapy, highly active antiretroviral therapy, precipitates insulinopenia or insulin resistance and brings the occult diabetes to overt. These are the mechanisms involved in that, and this diabetic food, for want of time I am trying to do that, but this is a very excellent classification. If you follow that, you will be able to save the limbs. Here today, limb salvage is not the thing, limb saving, and always try never have a conservative approach in the surgical debridement and take care of the pulse. And this is a word about the prevention of these infections. Food we know, but in the genitourinary system, hygiene always improves, and the lung infections, vaccination against pneumococcal influenza, H1N1 is always important. These are the few warning signs when you are dealing with a patient of a long-standing diabetes, especially a poorly controlled diabetes. Clinicians should concentrate on that. And these are the treatment principles. What I would like to stress is, one side there is an infection, another side is metabolic disorders. Both can aggravate each. And there are reasons that these infections also precipitate diabetes by any one of these mechanisms. Direct destruction of the beta cells, molecular mimicry, increased processing and presentation of autoantigen, increased inflammatory reactions, increased insulin infection, during infection, and insulin resistance. These are the ways, and the learning from these peculiar infections in diabetes is, ladies and gentlemen, diabetes milieu is an infection menu. You can always say both of them are very closely linked. Diabetic mellitus promotes infection, infects promote diabetes. The key is you will have to suspect early and detect early, and adequate drainage, never be conservative. Adequate drainage and good antibiotic protocol as per your institution, and you must remember peculiar organisms, peculiar sites, and the peculiar presentation of even a common infection has to be there. Remember, humoral immunity is normal in diabetes. Therefore, a vaccination has a definite role in prevention of the lung infections, especially in diabetes long-standing who happen to be, smokers, not willing to leave them. Thank you, ladies and gentlemen, for your kind attention.